Greetings, everyone. Apologies for the slight delay. We are delighted to see you here again at another insightful A&T Neuro webinar. I'm Farnoosh Saadi, Head of Education Department at A&T Neuro, and today I have the pleasure of hosting this webinar on wearable EEG monitoring in epilepsy, insights from the EEG Home study. This webinar will be presented by Dr. Andrea Biondi, who is a neuroscientist and psychologist specializing in wearable technology, digital health, psychophysiology, and neuroscience. Following his PhD, he is now working as a postdoctoral researcher at King's College London. He is involved in several projects aimed at developing feasible procedures for remote monitoring and integration of digital mental health interventions in epilepsy care. These new procedures could enable patients with epilepsy to independently and safely collect daily at home EEG data using new technologies, reducing the gap between mental and physical health care in epilepsy management. After this insightful presentation, we'll watch a demo by Kritika Chowdhury, our Head of Customer Success at A&T Neuro. During the presentation, please feel free to type your questions. We'll address as many of them as far as the time allows. We'll also have some poll questions, and we appreciate your active participation. So, Andrea, thank you again for accepting our invitation. Without further ado, we can't wait to hear about your findings.
Thank you so much for the invitation. I'm very happy to start discussing about this project and in general giving an overview about wearable EEG and solution that can help monitoring people with epilepsy. I would like to start mentioning why we focus in our team on epilepsy. So we focus in epilepsy because it's one of the most common neurological disorder, which, as we know, affect around 65 million people. And one of the biggest issues with epilepsy is the fact that these patients experience unexpected and sometimes unprovoked seizures that affect life of these people from different point of view, especially in people which are also resistant to specific anti-epileptic drugs. So despite they take medication, they continue to have seizures during their life. And this can affect life from different point of view, especially, for example, from the quality of life, from their mood. They can sometimes increase because some people report additional cognitive problems. And it's very important to find solutions that can allow clinicians and to improve the monitoring and the management of this neurological disorder. I would like to start describing what is the procedure that we use now for the diagnosis of epilepsy. The gold standard procedure is the use of an inpatient video EEG recording. So the patient is go to the hospital. An EEG is connected to the scalp of this patient, which is going to be monitored 24/7 to increase the chance to capture on the video on EEG any potential events. There are some limitations with these solutions, despite is the most efficient one. There is some limitation about the setting because people are not in their house or in their routine, but they are in the hospital, so not a real natural setting, we can say. It is a bit expensive. There is the need of 24/7 support from technicians, clinicians, and there is also a limited number of space. So there is a patient list because every hospital has a specific number of beds and equipment that can be used for these patients. Finally, there is a limited number of days that people stay in the hospital for multiple reasons, for their job, for example. And usually this examination runs from 4 to usually 10 or maximum 15 days. There is a solution that is, we can say, not new, but newer compared to the inpatient video EEG, that is the outpatient video EEG. So the patients go to the hospital or they receive at home people who set up the EEG, still with an EEG cap, with some glue, with the gel. Plus, there is a portable, despite not the most portable, we could say, solution. As you can see in the bottom, there is a system with a bag, the computer, the EEG system, the amplifier, cables, and a video camera that allow to monitor the patient for 24 hours for a couple of days, usually 2, 3 to maximum 4 days. It is a very good solution for several reasons, because patient's routine can be partially preserved. Patient doesn't have to go to the hospital, so for some people it's better because they cannot travel. And still, most of the events can be captured. There are still some limitations, because of course patient is still not completely natural free, because the movements are still limited. The solution is still expensive. There is a need of technicians, of specialized nurses, and there is a limited number of systems that are available, and there is a specialist, as in the inpatient's EEG. So what happened during the last, we would say, 10 to 15 years? So clinicians and researchers start to ask themselves, what can be used in the future to improve this, this procedure, and how new technology can help people with epilepsy? And there are several ideas. So there are some studies and some teams that suggested how the use of multiple solutions can be used to identify, for example, some triggers, or if there are any changes, for example, in the heart rate or in the EEG, or in any information that can help to manage this disorder. Another option is to use, for example, non-invasive or semi-invasive or any new electroencephalographic solution to monitor patient for a long time, not a couple of days or but a couple of weeks or a couple of months continuously, to be able to detect or predict in real life any potential seizures. I would like to start now describing several solutions that are available, and these were also part of the work I did during my years at King's College London. So patients can be monitored using, for example, new EEG, but in the same time, there is a lot of solutions that are more portable, like watch or a wearable device, that can be used in the same time with EEG solutions. So we performed one study, for example, called Radar Epilepsy, that ran from 2017 to 2020. During the while, we asked people with epilepsy in the hospital and at home to use different solutions during their time in the hospital, and we asked and we tried to understand if the patients were able to use the device, which one they prefer, if they were able to use, which one was the barrier, and any potential information that could help us to understand if it was possible to remote or collect biosignal using new solutions. We got positive results, interviewing the participants, using questionnaires, and checking this patient, for example, in the hospital for days. And we found important information that help us to develop in the future EEG HOME, the study that I'm going to describe later. So we understood, for example, from the study that patients were happy to use this solution, especially if they were not visible, like watch, that the device, of course, needs to be comfortable, it's easy to use, so easy to apply and easy to control. And one of the most important information for us was also that patients are able to self-manage some of these devices with a minimal supervision. And we also found out that the age or the scholarity or other demographic information are not really affecting the compliance or the ability of using these solutions in the hospital or at home. Then we also started studying the potential use of new electronic diaries. It is well known that using diaries is very important in patient with epilepsy. So the standard procedure is that patients has a visit with a psychologist or consultant every 3 or 6 months, and the patients report the clinicians how many seizures they believe they experience during this time. And being this information very important, during the last also 10 years, there was a huge development of new solutions like smartphone app and a solution that could help patients, caregiver, and healthcare provider to obtain additional information that usually are not available in a more standardized way, and also in a way that clinicians can check, for example, rapidly or easily or adapting to the patient's needs. I and other colleagues decided to also understand the value of this information and how much this self-report information are precise. So we perform a short review of the literature to understand the precision of self-report information in paper diary, but also in electronic diary. We found a group of studies, around, we would say, 9 studies that compared the number of seizures collected, for example, in the hospital or at home using scalp EEG or implantable EEG, and we compared these results with the number of seizures that patients report by themselves in their diary. And we found out that the results are, we can say, good for some patients, but not for everyone. So around 60% of the seizures usually are not reported. But it's also important to understand why and when. So we found out that there are better performance when the seizures are not, of course, associated with the loss of consciousness. There are better performance when the seizures are associated with stereotypic movements or something that is very, very visible also from the caregiver. And we also found that there is some group of participants that may be more capable to report seizures. So this means that it's important to have information about seizure or potential triggers or medication compliance using these diaries. But it will be also important to have another solution like an EEG that can improve the precision of these diaries. For this reason, we decided to have an overview on all the available solutions. As we said, there are, as you can see on the right, scalp EEG or intracranial EEG, or scalp EEG for outpatient and ambulatory video. And we found that any different EEG solution available and protocol could have their advantage and their disadvantage. Here, we want to focus especially on the non-invasive, the one that we call non-invasive solution, can be also called portable or mobile, because we want to talk about solutions that can be wear by the participant whenever they want, remove whenever they want, or that they are very easy to wear or easy to remove and manipulate. The main advantage of this solution is that they can be wear in a very short time, they can remove in a very short time. The cost is, of course, less compared to the other, also because the support and the monitoring and the application is easy to also apply. But there are not a lot of studies talking about these devices. For this reason, we started performing a systematic review that we published a couple of years ago, investigated and trying to understand which were the potential application and which was the application on that time of non-invasive portable wearable or mobile solution. So any type of solution that can be wear by patients without surgery or without the support of a real technicians. And we found out that there are not many studies focusing on this topic. But we also found out that the use of, for example, low number channel mobile EEG or multiple cap or multiple cap with multiple channels can be used in the hospital, but also at home for multiple reasons. They can have monitoring patient for a long time, so collect a huge amount of data. It can enable patients to easily apply and remove the solution. They can improve movement. They can reduce the cost. Despite this, the application of these solutions in the clinical practice is still very, very poor, if not, I would say, that it's not really used up to now. The only couple of examples that we found is, for example, the use of a solution called Bytefly. Sensor dots that you can apply and remove to collect multiple information like ECG, EEG, movement, that can be used to collect, for example, 24 hours data, and then combine this data all together in a, we could say, in a comfortable way. solutions, for example, that are available are from a company called SIR that develop mobile, we can say, a more comfortable home ambulatory system that allow easier movement to patients during their ambulatory EEG and allow the data to be shared with the clinician. So this, we can say this one is an improvement of the one I described at the start of the study. So the error of the presentation, a new ambulatory solution to collect data in a more comfortable way. Plus, as we said, there are subcutaneous solutions. So devices that can be implanted and allowed to collect data for 24/7 for a long time, up to 1 year or 6 months. And as we said, these solutions are very good because stable as they are implanted. But not all patients will be available to wear a solution like this one, or probably it's not needed for any reason. For all these reasons, and after having all this information together, we decided to develop our own protocol. So we decided to develop the EEG HOME study. So our aim from the start was to develop a protocol that could allow people with epilepsy to collect all the data we described, so EEG, heart rate, information about potential triggers from their home in the most independent way, so with the lowest level of support. And we wanted to validate this procedure and test for the first time a procedure like this one to help these patients, but also to help this field and understand what will be done in the future. So what we did was enrolling 12 participants with drug-resistant epilepsy, and we asked these people to undertake twice a day, morning and afternoon, at home, of course, 5 to 10 minutes of EEG using a portable EEG, and then collect additional data using a wrist-worn device, like a smartwatch, and a seizure diary. Our 3 main points was to understand if the patient acceptability and feasibility of the procedure. We want to understand the quality of the data collected independently by people with epilepsy. And finally, we wanted to investigate if there were any association between the data collected, for example, the EEG with the heart rate, or the heart rate with the number of seizures reported, and understanding also if there were any temporal pattern in this data in specific participants. So as we said, we used these 3 solutions. We used the SIR medical app to ask people twice a day to report any information about seizure, mood, stress level, or sleep quality. We ask people to wear 24/7 a Fitbit Charge 4. Fitbit is a non-invasive device that you can wear, and it has a photogrammetry, an accelerometer, and a sleep, and an automatic algorithm to measure sleep. And then we use the AND cap. That is an 8 EEG dry channel solution that allowed us to collect EEG with these people for 2 times per day, with minimum support. What we initially did was also to develop a remote procedure. So we consent these people remotely via email or via with specific software that allow people to electronically sign the consent form. We call them by phone and via video call to train them, to explain them how to use the device, to explain the study. And we also decided to deliver all the equipment via postage to reduce, also because there was the pandemic in the time of the study, to reduce any chance of contact or any potential issue. We wanted to be safe 100%. What we did, so we provide them also with guidelines. This one is an example of a guideline, and that one, of course, is me when I was trying to explain people how to use the EEG cap. So I show which one was the equipment, so the EEG cap, the amplifier, the laptop. We explain them step by step how to wear the EEG cap. And then we explain them step by step how to use the software independently with 3 to 4 trainings. So we did 3 trainings of more than 1 hour for each participant. During the while, initially, we show how to use the software. We show what happened during an EEG, and then we ask them to independently follow on the procedure. This is, for example, one of the participants using the EEG system at home with the support of the caregiver. And you can see from the left, from the top to the bottom on the right, what the steps they follow. So they have to prepare the EEG, connecting the amplifier, wearing the EEG cap, closing the EEG cap, adjusting the electrodes, and then they start collecting the EEG using the software. So they start recording, the participant close their eyes 5 minutes to 10 minutes, and then they stop the recording and they save the file, and they repeat this task at 2 times per day for 6 months. Then we have other examples. So some participants decided to use the software on a different setting, because we ask them and we try to be flexible, giving them the chance to collect the data in the more comfortable way. This participant was collecting the data while the participant was doing meditation, because the participant found this very comfortable and relaxing. Now, I have some questions because I want to see if you are able to pass the online training that the participants were doing. So I'm going to show you some figures of EEG segment that the participants were collecting. And I want to see if you can get which artifact they see from these figures. And this one is the first figure. And now I would like to know from you which artifact you can see from this EEG recording.
The first poll is ongoing, and we'll give it 60 seconds or so. All right, more than 70% of the participants have voted, so we can close the poll and share the results. Can you see the results, Andrea?
No, can you tell me, please?
Okay. If not, I can read them out for you. So 70% go for blinks and eye movements, 20% for electronic artifact, 10% for movements.
Then you are completely right. So we're going to go with the second one, because the first one was a blink and eye movement of the participant. Now I'm going to show you the second one, this one.
Could you please make it full screen, Andrea?
Yes, of course.
Shall we share the poll?
Okay.
All right, we can close the poll and share the results. This time, the majority of the participants voted for electronic artifact, while 11% went for movements and another 11 for blinks.
Yeah, and this one, this one was a strong electronic artifact that we couldn't understand initially what was that, and then we found out that it was just the smartphone of some patients very close to the amplifier, because they used the smartphone as an alarm, and they place the smartphone very close to the amplifier, and we found out only after a couple of tests. So we can go to the next one, that is this one. Sorry, let me share again the screen. So this one. Hope you can see it.
Yes, that's visible. We can share the next poll. Oh. And we can close the poll question. Let's see the results. So the results this time are quite a mix. So 56% voted for artifact at all, 31% movements, 6% electronic artifact, and another 6% blinks eye movements.
Yeah, in this case, there was nothing. I'm sorry for if it was a bit tricky, but in this case, there was obviously, I mean, not obviously, there was nothing. It was just eyes closed. In this case, like said, with no movements or any major blinks or movements or electronic. And just the last one that I can get, now you can get it also excluding the other.
Let's vote for the last one, who is ongoing.
Yeah.
All right, so let's close the poll. And the results say that 86% for movements, 14% for electronic artifact. Yeah.
Very good. So it looks like most of the people would easily. And okay, so let's okay, so we can continue. So after this, what we decide, we're going to focus on the feasibility and acceptability of the study that we mentioned. So we enrolled a participant, and then we set the adherence with the opinion and the usability of these solutions. So we interview the participant, but we also ask them to complete questionnaires about the usability of the solution for several months, for every month. We found out that most of the people used the solution with an acceptable level of adherence, around 60% for the EEG and the questionnaires, and around 90% for the watch. That makes sense because the watch is a more passive solution, so they have just to wear the device and charge it every couple of days. We have only 2 participants who decided to stop study for personal reason, a job specifically. So we had an 83% likelihood to complete the 6 months of the study. And we also found out that if we focus only on the daily use of the system, so instead of asking 2 times per day, but 1 times per day, the adherence is much higher, close to 80%, both with the EEG than with the questionnaires. And finally, we also found that asking every month the level of usability and acceptability of the device, will the device obtain a positive score, so an acceptable level of usability, especially when we talk about the watch. That was the easiest one to use. When we interview the participant, we also found very interesting point. So we interview the participant, we start the most important topic, and for each one of them, we extract specific themes and topic. For example, we understood how important was having a routine for these people to become more familiar with the procedure. We understood how their desire to share the information with their health provider about protecting this information. And we also found out how it was important to be involved in a research and allow them to collect their own data. So they felt empowered. Now the last question. So on the other side, which were the most common technical problem that the participant experienced using our EEG system? So I wonder, in your opinion, which one was the most common? And then I'm going to tell you which one was the real one, in order, which one was the most common and which one was the less common. No.
All right, most of the participants have voted by now. Let's see the results.
Mm-hmm.
And the results are again quite a mix. 24% having to use a laptop, 41% EEG cap being uncomfortable, 12% duration and or frequency of recording, 24% lack of feedback. Is that aligned with your expectations?
It's almost realistic. The most common was having to use a laptop, as you expect. It was because it reduced a bit the feeling of using portable solution, and it didn't allow most of the people, for example, to bring the solution when they were, for example, traveling, because some of them they were traveling and they want to use the solution, but they couldn't because they couldn't bring with them the laptop, or if they were on holiday, or if they were traveling to their family members, or while the second one was the duration and the frequency of the recording. As we said before, some of them were okay using 2 times per day, but most of them prefer to use only 1 time per day and being more flexible to using, for example, in the evening or in the morning. And then there was the lack of feedback. So patients, most of the patients wanted to share this information immediately with the clinicians and ask the clinicians if they can get any feedback from them. And the less important, the less common was the uncomfortable, because all the participants found the very comfortable and easy to use. So it was just from this point of view. Finally, we want to describe the from the video, which were summarized in the table you can see. And the main point that we found is that participants were happy to use the device and were happy to use the solutions. one of the most important improvements for the future for this solution is to be able to be flexible and to be able to tailor and adjust solutions based on participant needs, participant interest, and participant symptoms. Another important point with that.
Andrea, sorry for interruption. Would you mind making your screen to full screen? And I'm not sure if you're following the right slide.
Yes, it's now working.
Now, perfect. Thank you.
Yeah, I was mentioning that it is important to tailor this study and adapting it based on patient needs and being able to share the data with the healthcare providers. It's important to provide periodical feedback if possible. It was important finally to focus on the fact that participants were happy to be supported online, so it was possible to support people online. It is obviously important to also give them the possibility to have face-to-face support or training if there is a major problem. And finally, it is important to highlight how none of the device was defined uncomfortable. Also, the EEG cap, despite the visibility, was found a very good device, especially if it needs to be used at home. And some of the participants also mentioned how they would be happy to have a solution like that compared to the standard solution if their consultant or if their healthcare provider asked them to use the device, for example, after a change of medication or to obtain additional information regarding their epilepsy. Do we still have time, or do we need to go to the end of the presentation?
You can have a couple of more minutes.
Okay. So before concluding, I would like also to show, for example, in one of the participants, we wanted to check if the data collected also had good quality, as we mentioned, or if they can be used for clinical reasons, and if the participants were able to collect meaningful data. So we start checking all the data collected by all the participants, and in this case, I'm going to show you one participant who collected by herself around more than 305 to 10 minutes EEG. We asked 3 EEG experts to check all these recording to understand if it was possible to identify any absences or any other events that can be useful from a clinical point of view. On the top, you can see an event that the participant experienced in the hospital years before the start of the study. And on the bottom, you can see what the participant managed to collect using the ALD system. It's very interesting because we managed to find around 40 events like this one in the multiple recording. It is also interesting to report how only in 4 cases the participant also described in her seizure diary that the participant had an event or a seizure on the same day. So only in 10% of the cases the participant reported an event on the same day. This means that the system that we use can provide additional information compared to our diary, and that the data collected can be used probably in the future to develop a seizure detection algorithm or a seizure spike algorithm, and that is really important to use in the future solution like this one to collect clinical information and EEG on patients. There is also a final topic that is a bit longer, so I think it's better if we just go to the conclusion. If it's okay for you.
That's perfectly fine. Thank you.
So, Madi, from the EEG HOME study, we managed to develop and test a protocol that allow people with epilepsy to independently use multiple wearable devices, smartphone app, and standardized questionnaires for over 6 months. We managed to collect EEG, ECG, sleep, stress, and additional information for multiple months. And we also investigate and confirm the usability and the acceptability of a solution like that. What needs to be done in the future with the protocol like this one is to get all this information and being able to share this information automatically to clinicians and analyze automatically this data over the time. It will help to improve the chance to identify, for example, period with higher seizure risk and help the management and the daily life of people. In conclusion, our vision is that, as you can see from the left, that many factors can affect the decision to start a remote monitoring safety of blood. Clinical characteristic, points related to the device that you're going to use. Then what will happen after the decision making is that the clinician can choose the level of monitoring. So you can have a low level of monitoring, for example, using just using a smartwatch. Or you can have a higher level of monitoring, so with multimodal monitoring and long-term monitoring, using also possible for a mobile EEG. Finally, we strongly believe that in this way, multiple information can be collected, stored, and can be shared to patients, care provider, caregiver, but also with research and developers. And all this information improves not only the development of new solutions for monitoring, but will also improve potentially outcome and management of this disorder. I would like to thank you everyone for your attention.